Hello guys, so today we are going to discuss a very important topic, emphysema. Emphysema is a chronic progressive lung disease and it is characterized by permanent enlargement of air spaces distal to terminal bronchiole. Here what happens is a destruction of the alveolar wall which results in increase in lung volume, but the total lung volume is decreased, and also there is loss of elastic recoil. The lungs, when we inhale, the lungs expand, and when we exhale, the lungs compressed. Okay, so when the elastic recoil is lost, then what happens is we inhale, air enters into the lungs, okay, but it traps in there. The lungs don't compress like the same as in the normal phenomena. So there is loss of elastic recoil, then air trapping and hyperinflation, when then absence of significant fibrosis. Okay, and what is the ATS definition of emphysema? ATS definition describes that abnormal permanent enlargement of air spaces distal to terminal bronchioles and accompanied by destruction of alveolar walls. And what is the and its epidemiology? If we talk about, then in the worldwide statistics, there is a 300 million plus population which is affected by this, and emphysema is a major pathological subtype. Risk factors, if we talk about risk factors, then they include smoking is a very important risk factor worldwide, and then occupational exposure to some toxins which result in the destruction of the walls of alveoli, and air pollution, then biomass, fuel exposures, genetic predisposition is also a common cause, and then if we talk about gender, so it's most common in males, and incidence in females is also increasing due to the trend of smoking especially in the Gen Z and all. Then if we talk about the normal alveoli, normal anatomy of the alveolus, then its components include the terminal bronchioles, respiratory bronchioles, alveolar ducts, and alveolar sacs, capillary networks. And what is the function of the normal alveolus? So gas exchange, elastic recoil, and maintenance of air patency. These are the three functions of normal alveolus. And when the normal alveolar walls are destroyed, the alveolus is also destroyed. What it results? It results in no gas exchange, no elastic recoil, and abnormality of air patency. Okay. Now we talk about the pathogenesis. So the major mechanisms involved in the pathogenesis of emphysema include protease and anti-protease imbalance. This is a very important. Then oxidative stress, the chronic inflammation, and apoptosis of alveolar cells. But it results in alveolar destruction, loss of elastic tissues, which result in loss of elastic recoil, air trapping occurs, and hyperinflation occurs. Then the hypothesis, very important. Protease anti-protease hypothesis. What it says: protease include neutrophil elastasis, matrix metalloproteinases, and cathepsin. Okay? And anti-proteases include alpha-1 antitrypsins and secretory leukoproteases. And what it affects when there is a abnormal or a imbalance of the protease and anti-protease, it results in excess proteases. These proteases result in destruction of elastin, collagen, and alveolar wall. And in short, if we talk about this protease anti-protease theory, so it says that smoking increases proteases, including the neutrophil elastasis activity. This activity results in destruction of alveolar wall, and the alpha-1 anti-protease normally inhibit these elastases, and smoking increases the neutrophil elastase activity, and the smoking oxidizes and inactivates these alpha-1 antitrypsins, which result in progressive alveolar destruction and loss of elastic recoil, which is a major phenomena in the pathogenesis of emphysema. Now we talk about the role of smoking. So the harmful effects are recruits inflammatory cells, increases neutrophils and macrophages, generates free radicals, inactivates alpha-1 antitrypsin, and accelerates alveolar destruction. And if we talk about the statistics, 80 to 90% of emphysema are associated with smoking. That's why I talked about the risk factors. In the risk factors, smoking is a very predominant cause of emphysema. And alpha-1 antitrypsin deficiency is a genetic emphysema, and alpha-1 antitrypsin functions is inhibit elastases, which are antitrypsins. Okay, and the deficiency results in early onset emphysema, severe pan-acinar emphysema, and low lobe predominance. And inheritance, it is a autosomal codominant. So we talk about the types of emphysema. So there are 4 types of emphysema: centroacinar, okay, then panacinar, distal acinar or paraseptal acinar, and then irregular emphysema. Centroacinar. What is centroacinar? It is a characterized most common type affects respiratory bronchioles, and distal are spared. So location is upper lobe. This is important for MCQ's purpose, and it is strongly associated with smoking. Now we talk about the next type, which is a panacinar. It is an entire acinus uniformly enlarged and destruction of respiratory bronchioles to alveolus, and its location is lower lobe and associated with alpha-1 antitrypsin. These are 2 MCQs. You can have faced them in MCQs portion. And then paraseptal emphysema. It involves distal acinus and adjacent to pleura. Complications include the bulla formation and spontaneous pneumothorax, especially in young. And now we talk about the last and 4th type, which is the irregular emphysema. It is characterized by irregular involvement of acini and is associated with scarring, and the clinical importance because of asymptomatic nature. So this is a table for knowing the types of differentiating the 4 types of acini of emphysema. So upper lobe, lower lobe, peripheral acinus, and scarring, and with association. So this is a very important topic for your MCQ's purpose and for differentiating the 4 types of emphysema. Now we talk about the pathological changes which occur in the emphysema. The gross pathological findings includes the enlarged lungs, hyperinflation, then bulla formation, and reduced capillary bed. Microscopic findings include alveolar wall destruction, then enlarged air spaces and loss of elastic fibers. And pathological consequences include the airflow limitation due to loss of elastic recoil, dynamic airway collapse. Also it includes the destruction of the alveolar wall, which results in the increase in lung volume but decrease in total lung volume. And consequences include the air trapping, hyperinflation, increased residual volume, and reduced expiratory flow. And then we talk about the clinical features, how the patient is going to present. A patient will present with major symptoms including the shortness of breath or progressive dyspnea. The patient says that he has a shortness of breath after walking. Earlier he was not having this kind of shortness of breath, but now he when he walks 100 meters or 200 meters, he starts having shortness of breath. For that we also use NYA classification. There are 4 classifications. First patient is normal, then the patient is having a shortness of breath after walking, then the patient is having shortness of breath after 100 meters of walking or upstairs, and in the 4th one the patient is having shortness of breath after minimal activity like changing clothes, and well also in the rest. And then we have reduced exercise tolerance, and then chronic cough, wheezing, fatigue, and advanced disease has weight loss and respiratory failure. We talk about the signs on inspection of the chest. First always go with the general physical examination also if you talk, and then with the chest examination. So in the chest examination you will have barrel shaped chest or the barrel shaped chest. Normal the chest is this, okay. So the anterior-posterior diameter is less than this diameter. So in the barrel shaped chest what happens is the anterior-posterior diameter is increased, and we have prolonged expiration because there is a loss of elastic recoil and airflow trapping. Also the patient is having pursed lip breathing, and on palpation we will have reduced chest expansion, and on percussion there is hyperresonance. Normally it's resonant sound because of the air, but when there is a destruction of the alveolar wall, there is more air in the lungs, more air in the chest. That's why on percussion we will have hyperresonance. On auscultation there is decreased breath sounds, and wheezes can also be. Pink puffer is a very important differential for here. We have to know that it is a classical phenotype characterized by thin body habitus, severe dyspnea, minimal sputum, and hyperventilation, then near normal oxygenation initially. And the patient has an appearance of pink puffer. Now we talk about the investigations we have to do in a patient we are suspecting to have emphysema. So include diagnostic. First it is a clinical. Okay, then we have some essential tests like spirometry, then chest X-ray, and HRCT, ABGs we have to do, and alpha-1 antitrypsin to diagnose the type of emphysema. Okay, so in spirometry it is a pulmonary function test. Findings include that FEV1 over FVC ratio is decreased by less than 0.7. Okay, then reduce FEV1 reduce FEV1 over FEVC ratio, and increase total lung capacity, and increase residual volume, and decrease diffusing lung capacity of carbon dioxide. Okay, and the diagnostic of obstruction is persistent post bronchodilator airflow limitation. In the if we talk about the asthma, in asthma there is greater than 20% increase in 20% increase in oxygenation or after peak expiratory flow meter readings after the bronchodilator. We talk about the chest X-ray. In chest X-ray, there is hyperinflated lungs, flat diaphragm, increased retrosternal spaces. Okay? Now, see, this is a normal. This is a normal X-ray where we have a lung. Okay, the visible demarcations of the alveoli and we have this diaphragm, normal diaphragm curvature. In the emphysema, this is emphysema. So we have hyperinflated lungs, reduced markings of the lungs, and flat diaphragm. Also we have hyperlucent lung field and narrow cardiac silhouette. Okay. Now we talk about the HRCT findings, which include the areas of low attenuation. Bulla formation can occur, air trapping, and destruction of alveolar architecture. And advantage is that it is the most sensitive imaging modality. Initial is always X-ray. Then we go for ABGs in a patient we are having with the hypoxemia. So in early disease there is mild hypoxemia, and in advanced disease there is severe hypoxemia, hypercapnia, and respiratory acidosis. And differentials include chronic bronchitis, then bronchiectasis, then asthma, then interstitial lung disease, and then heart failure. And we talk about the management. So the goals of the management are, first one is to relieve symptoms, always relieve symptoms, then improve the quality of life, then reduce exacerbations and slow progression, and improve survival. Now we talk about the smoking cessation, important in the management of whether it's asthma or whether it's emphysema, and also in most of the pulmonary diseases. So it is the most effective intervention. Benefits include the shows decline in lung function, reduce mortality, improves symptoms. Methods include counseling, nicotine replacement patches, therapies, and varenicline, and then bupropion. You have to learn these and go from stepwise, and these steps should be done in the same sequence. It's very important for MCQs. The patient presents to you with the emphysema, or he wants to quit smoking or for smoking cessation. So always go for counseling first. If the patient is not having progress or the progress with the counseling, then you go for nicotine replacement patch. And then if this is also a failure of treatment, then you go for varenicline. And then if this also, then you go for bupropion. Okay, so sometimes in the scenarios they have given that the patient is not willing for nicotine replacement patch, like in this AMC question, the patient they have a scenario where the patient had not benefit from counseling, and he also has shows reluctance to using this nicotine replacement. So then we have to choose varenicline. Okay. So now the next is pharmacological management. So it includes the bronchodilators, first of all, including the short-acting and long-acting beta agonists. Then we use inhaled steroids. Steroids, what do they? Reduce the inflammation, and also indication in frequent exacerbations, elevated eosinophils, and asthma COPD overlap. Then we use pulmonary rehabilitations, includes exercise training, nutritional support, patient education, breathing exercises. Benefits include the improved exercise capacity and reduced dyspnea. In the oxygen therapy, the long-term oxygen therapy indications include chronic severe hypoxemia. Benefits include improved survival and better quality of life. Recommended greater than 15 hours per day at least. For a patient with the COPD, he should be prescribed to have long-term oxygen therapy for greater than 15 hours per day. You have seen some patients in a very few years ago, I think so. I was having a video where I was seeing a patient, a rickshaw patient, he was having COPD and severe COPD, and he was having oxygen cylinder in his rickshaw for his oxygen requirements. So in the surgical managements include large lung volume reduction surgeries, which removes non-functional emphysematous tissue, and lung transplantation is also an option, but it is for end stage and very rarely done, and endobronchial valve therapy for selected patients. So the complications of the COPD include respiratory failure, pulmonary hypertension. Core pulmonary is a very important concept for this, recurrent infections, pneumothorax, and blood formation. Then we talk about the prognosis, then depends on the smoking status. First of all, most important is the smoking status. Then we talk about the severity of airflow obstruction and frequent exacerbations, nutritional status, and presence of hypoxemia. Poor prognostic indicators include the low FEV1 value, hypercapnia, and pulmonary hypertension. The preventions include the primary prevention, and including that is avoid smoking, reduce occupational exposure. Most of the occupational chemicals are responsible for this COPD, so we have to reduce the occupational exposures, also control of pollution. Secondary preventions always include early diagnosis, vaccination, and pulmonary rehabilitation. So this is a very important table for differential diagnosis of how we are going to differentiate between the emphysema and the chronic bronchitis. So the main problem in the emphysema is alveolar destruction, and in the chronic bronchitis it is mucus hypersecretion. Diffusing lung capacity is decreased in emphysema, while it's normal in the chronic bronchitis. And habitus we talk about, it is a thin and it is in overweight. So it is a thin and is a, that's why emphysema is called pink puffer. It's not writing. So and then we talk about the sputum. So it is minimal in the emphysema, but it is productive stuff in chronic bronchitis, and the cyanosis is an early feature in chronic bronchitis, and the core pulmonary is also an early feature in bronchitis. If you have any query, you can ask me in the comment section. Thank you so much for listening me.